welcome to this webinar titled DSN Forum Decoding NG28. What does that mean for our clinical practice? What do the new type 2 guidelines mean for our clinical practice? This webinar has been kindly sponsored by AstraZeneca. However, they have had no input into the content or agenda. They have just sponsored the video that you're going to see shortly from Sarah Davis. My name is Amanda and I'm a DSN in Kent. Please let me introduce my fellow DSN Forum colleagues. We have Beth.
Hi, yeah, so my name is Beth Kelly. I'm a diabetes specialist nurse for Wiltshire.
And we have Vicky.
Hi, I'm Vicky Alabraba. I work for the Eden team at Leicester Diabetes Centre.
And Tamsin.
Hi, I'm Tamsin Fletcher-Salt and I'm a diabetes specialist nurse at the Royal State University Hospital.
So I just want to say thank you all for joining. We're going to go through a few things. So we're going through a bit of a background as to, why the NG28 guidance has been updated. We will show you a video from Sarah Davis and talking all about what to expect in the new guidelines, what does it show. And then we'll have loads of time after that for some conversation. So we want all of your questions, please. So as many questions as you can think of, please put those in the Q&A box for after we've watched the video. That's when we'll be able to discuss all of them. So I'll hand over to Beth, who's just going to give us a little bit of a background as to why the NG28 guidelines have been updated.
Yeah, so it's been a bit of an exciting year, isn't it? And I think we're all quite excited to see the new guidance be released and what it would mean for us. And I think we've been waiting so long now because, well, I'm sure everyone works in diabetes. It never stands still for us, does it? There's always something coming out, new evidence and things. So I think going back the last kind of decade, we've had, I think the Scottish guidelines were kind of the first sort of guidelines that we were seeing back in 2017, which sort of were looking at maybe more of the newer therapies that we had and looking at the evidence base and sort of trying to kind of take us on a journey of what might be the future. And after that, obviously, we had the American and European consensus document coming out in 2018, which was again updated in 2019. We had the European Society for Cardiology give us some guidelines for what we should be using with regards to neurotherapies as well. And then we had the Irish guidance as well. So since the last NICE guidance we had, which was brought out in 2015, we've had all of these guidance, new consensus guidance coming out. And along with that, lots and lots of all the new cardiovascular outcome trials, the CKD trials, all of that kind of showing us all of this massive wealth of evidence that we have. And obviously the NICE guidance just took a while to catch up, didn't it? So back in England, we've been waiting a long time for some guidance to catch up with all of the new evidence that we've got going on. And I think as specialists and, people that work with people with diabetes, we've come very used to using maybe or outsourcing kind of and bringing in other guidelines rather than using the NICE guidance that we had because it was kind of outdated. So I think it kind of, the background to how important these new NICE guidance is for us is kind of exciting, and as I said, we were very eager to see what it would bring, and so they are finally here. So 7 years down the line, we've got an update. Still wasn't a full review, so it's still not quite what we'd maybe hoped for, and that the whole guidance would be reviewed, but it is a big piece of work, isn't it? So I think they've done little reviews. So yeah, we've had that in just published, so 2022 updated NICE guidance. So that's what we're here to talk about today. I think I'm going to pass to Vicky, is it, to talk?
No, it's me.
Oh, you're going to do it. Okay, that's fine.
Cardiovascular. So, people with type 2 diabetes, as we know, they're at an increased risk of cardiovascular related death and morbidity compared to people without diabetes. So there's a 32% increased risk of death, 3 times the risk of death due to cardiovascular events, 3 times increased risk of stroke, and 4 times increased risk of myocardial infarction, and 4.5 times increased risk of a heart failure. So in 2007, it emerged that there was some issues with one of our medications that we use to bring glucose levels down, so rosiglitazone. And the studies were showing that it was increasing the risk of myocardial infarction and cardiovascular related death. And so this is when all of the anti-hyperglycemia agents were needed to be tested for their cardiovascular risk profiles. So those trials looked at MACE. So MACE stands for Major Adverse Cardiovascular Events. And that is looking at things like death due to cardiovascular events, stroke, and also a myocardial infarction and hospitalization for heart failure. So all of the medications that we use today for diabetes have been through these cardiovascular outcome trials. So many of the DPP-4 inhibitors, they were shown to be non-inferior, but not really showing any kind of decreased risk in terms of MACE or hospitalization for heart failure. Then we have the GLP-1 agents, and so there's quite a few of those that were showing a decreased risk of MACE, but not necessarily any change, or there was no increase in hospitalization for heart failure, but there was no sort of decreased risk either. And then we come to the SGLT2 inhibitors. So we had the EMPA-REG outcome, the CANVAS. So that was EMPA-REG was empagliflozin. Then you have the CANVAS program, which is canagliflozin, DECLARE-TIMI, which is dapagliflozin, and then VERTIS, which is ertugliflozin. And the first three of those, so EMPA, CANA, and DAPA, all showed decreased risk of MACE versus placebo. So they're reducing the risk of that myocardial infarction, stroke, and mortality. And then also what they also showed was a reduced risk for hospitalization for heart failure compared to placebo. So some really standing ovation in the places where this was being presented when it first came out. So with all these amazing trial results, the pharma companies started to look at other parts of this. So they started also looking at renal. So I'm going to hand over to Vicky, who's going to talk to about the kind of renal trials that we've seen.
Yeah, thank you, Amanda. So from the trials that Amanda's mentioned, the EMPA-REG, the CANVAS, and the DECLARE-TIMI trials, they did also show reductions in kidney disease progression, but then obviously dedicated renal outcome trials began to happen. So Credence was the first of the dedicated renal trials, and it was the first trial to show benefit in people with type 2 diabetes with albuminuria and CKD. So that was really exciting. I think we all remember when that happened. And then following on from that, there was DAPA-CKD, which also showed benefits in chronic kidney disease in people both with type 2 diabetes and people without. So that was the first time that we'd seen SGLT2s being of benefit in people without diabetes. So again, really exciting data there for us. And just recently, actually, I think it was last week, the EMPA kidney trial, it's just been stopped early due to efficacy. And I think the results of that is going to be published later this year. So obviously we've talked about the cardiovascular benefits and the renal benefits. And now I'm going to hand over to Tamsin, who's going to touch on the heart failure trials.
Thank you, Vicky. So I mean, I think we've mentioned quite a lot of the trials that showed the cardiovascular benefits, and part of those cardiovascular benefits was related to heart failure. And I think it's been a relatively kind of new thing, in a sense that heart failure is now being talked about in combination with type 2 diabetes, whereas before it was very much separate entities, and people treated heart failure and then people treated diabetes. But now we've got a medication that's actually doing both, and we're seeing that more and more, that these medications are now being prescribed by the cardiovascular team and the cardiology teams to actually help with heart failure. So the trials that were dedicated really to looking at the heart failure data started coming out in around 2019. And again, dapagliflozin were leading the field really with regards to this, the trial data. They obviously did the DAPA-HF trial, and they also did a trial called Define-HF, which was related to looking at the symptoms and actually quality of life outcomes, rather than necessarily just looking at, you know, the heart and the heart failure and the ejection fracture. And that showed, you know, clinically significant improvement to people's lives, which was, you know, which is really what we're hoping for, is to actually improve people's lives with, you know, type 2 diabetes, who also have got the you know, the cardiovascular complications of diabetes. So obviously Vicky and Amanda both mentioned the Declare TIMI trial that showed evidence of heart failure, and then we've got an extension to like the EMPA-REG trial. They produced the EMPA Reduced and the EMPA Preserve trials, and both of those have come out and showed real promise with regards to treating people with heart failure with both preserved and reduced ejection fractures. And then canagliflozin have also done a trial, and that is called Chief-HF, and that one is the first of those trials that's actually been done that was completely remote and virtual due to COVID, and that ended at the end of last year, and also showed improvements in people with a heart failure, which I think is not unexpected, as we know that the class of drug has shown significant cardiovascular benefits across the board in all of their trials. So I think, you know, it was to be expected that obviously Cana was probably going to get very similar results and showed an improvement.
Yeah, so I think if anything, just going through all those trials and things just shows how we're really having in diabetes having to work across all three specialities and really up our game on knowing a bit about everything rather than just our own little diabetes world. We're having to expand our knowledge and know a little bit about heart failure and a little bit about kidney disease, and work across all three specialities.
Yeah, I wonder if one day we'll be doing multi-morbidity clinics with the other specialist nurses, because a lot of our patients are the same kind of patients, aren't they? So the renal, the heart failure patients, and they have diabetes. So I wonder if in the future, instead of having 3 different appointments to see 3 different specialists, we might end up having one multi-morbidity clinic with all the specialists together, working together as specialist nurses. Or maybe you become a multi-morbidity specialist nurse, so you're not just a diabetes nurse, you're a heart failure and a renal. I think that sounds too complicated.
Yeah.
It really does.
Yeah. I mean, I think you already have the renal diabetes clinics, don't you? You know, that are already pretty established across the board, but I think because, you know, cardiovascular complications are sort of known about, but they don't really talk about them hugely. I don't think when when you're speaking to people necessarily with type 2 diabetes, and it's becoming more of a thing now that these medications go across the specialities, that actually, you know, you can see that soon you're going to have a cardiologist and a renal doctor and a diabetes doctor side by side running outpatient clinics, and you're just going to end up going from one to the another to the next person, and just hopefully, you know, they do it all in one go, and you're not having to get people coming backwards and forwards, which is what they find now, and that I think find quite irritating to patients, that they're seeing 3 different doctors and they're all talking about the same thing.
Yeah, definitely.
You know, and that sort of thing. It's just frustrating for people.
I think it can maybe make the care a bit too fragmented, because obviously with this group of medications, so like you say, if a cardiologist is looking to start this medication, but the patient's got diabetes and they're maybe not quite sure what other adjustments might need to be made to the medication, then maybe a letter gets sent to primary care or to their diabetes team, whereas if it was all sort of done in one sitting, or there was maybe clearer channels of communication, then it's only going to be of benefit to, you know, to the patients at the end of the day. And I suppose we can all learn from each other, can't we, as well, from, you know, we get very used to working in our sort of silos, as it were, so by us working together, then we could kind of help each other really then, I think, as well.
Yeah, it's kind of like our everyday stuff. We kind of think, oh, you know, the sick day rules thing, we think, oh, that's kind of our basic bread and butter thing as a DSN, isn't it? But actually, when we talk to our heart failure colleagues, it is all new to them. And the same way as they talk about sort of, I suppose, basic heart failure stuff, we are totally mind blown by it. So definitely having some stronger working relationships amongst all three of us, I think, can only ever improve all of our knowledge. But I don't know if I fancy going and doing another master's degree in each of those other categories as well.
You'd be a cardio, renal, metabolic nurse specialist.
Yeah, a bit of everything.
So I think we're almost ready for our video. Please, can you open your chat box so that you can see the important information that will be put into the chat box there from AstraZeneca. As I said, that this part of the meeting is sponsored. And so, yeah, I think we'll get ready to play that. So we'll come off camera while that video is on, but please do think of any questions while Sarah's speaking. You need to sort of make a note of those, and then the chat will reopen. You can put your questions and answers in the box, and we can kind of discuss all of those. We want this to be a really interactive session where we discuss the points that are important to you, because this is why we put these meetings on, because, you know, what does it mean for our clinical practice, not just the 4 of us, but the 125 of you that are listening right now. So please do ask us some questions. So if we can have the video. Wow, interesting stuff. I think that gives us a lot to think about, doesn't it? A lot to go through. So what are your concerns about what Sarah's just said, about what the implications are going to be in terms of how do we do all of this? How do we start these people? Are you concerned at all? Do you think we're just going to what do you think, Beth?
I think, yeah, I mean, this was the biggest surprise to all of us, wasn't it? The whole dual therapy at diagnosis for those that are high risk or with established cardiovascular disease. And, you know, it's good. It's saying, you know, don't just have one drug and wait for things to go, you know, throw as much in as you can earlier. We know that the earlier you can get things in, the better the outcomes are for those patients. So, yeah, I think we know as DSNs, we've been using these drugs for what, a good 10 years, possibly longer now. We know, and we've come to know how they work and the kind of things we need to do and counsel the patient on. So I think, you know, we probably all do have a few, what are the words? Not doubts or worries, but just things that we need to make sure that we kind of get across that are mentioned to patients. So those would be kind of like your sick day rules or sick day advices we're giving patients, making sure that they're counselled on all the kind of things like genital hygiene and things like that. But common things come up, don't they, Vicky? Like, I don't know, what are the ones we hear quite commonly?
With regard to the sick day rule advice, you mean?
Or just starting SGLT2. One of them would, do they need to have blood glucose tests would be another one.
Yeah, I think probably when we first started using these in diabetes, and obviously the illness management advice, one of the common questions is, do you need to teach or provide your patients with the facilities to check for ketones? But if the most important advice really from when you're starting an SGLT2 inhibitor is giving that sick day rule advice. So obviously we're very used to doing that, but obviously people who maybe aren't used to prescribing SGLT2 inhibitors, it's making sure that you give that advice to your patients. So telling them that when they're not well, they need to stop taking the medication, and that's obviously to limit the risk of dehydration. So that's the most important thing. And that doesn't just apply to SGLT2 inhibitors. I'm sure you've all heard of the SADMAN acronym, the poor crying man, the SADMAN. There's a range of other medications that you do need to give advice, the similar advice if somebody's not well. So obviously that's one of the big things. And I suppose the biggest change for us as clinicians is we're not used to starting 2 therapies soon together. So I suppose it's just trying to get into that new mindset. I think it's good because hopefully from a therapeutic inertia point of view, it's going to help with that. We're not going to wait for things to either not be at target or above target or deteriorate. We're going to be proactively trying to stop that from happening in the first place. And I suppose it's just a stepwise approach. Make sure that your patients are tolerating their metformin sort of in that titration period, and then obviously add the SGLT2 inhibitor in sort of after about 4 or so weeks if they're tolerating the metformin okay.
Yeah, we've got plenty of questions coming through, so I'll start reading through those. So Jackie's asked, do you not start 5 milligrams DACA first? Tamsin, do you want to answer that one? You're on mute. It was going to happen to
one of them. It was going to happen at some point. Yeah. So no, it's 10 milligrams for the majority of people. The only time that they would recommend 5 milligrams is anybody with any hepatic impairment. So no, you would go straight in at the 10 milligram dose.
Okay. Work with our surgery to implement early. Okay, I think that's just a comment, that one. If I got it right, can we start someone with an EGFR 15 mils per minute or 50 mils per minute? I think all of those, I mean, I don't know if Vicky wants to answer this question. Yeah.
So yeah, there's different license indications depending on whether you're prescribing it for glucose management or kidney disease or heart failure. But the thing to remember with glucose lowering is once the EGFR is less than 45, the glucose lowering effect will be minimal. Obviously, they may need to be on that medication for a CKD point of view or a heart failure point of view, in which case you can use it down to a lower EGFR. But just bear in mind that the glucose lowering effect will not be as good. So you may need to think of additional glucose lowering therapies as well.
Yeah, just to remind people that the prescribing information is at the top of the chat box as well. So you can go away and just double check for yourselves all of the prescribing information.
And there's some really useful things from Kevin Fernando, he from the Goggle Docs, our friends. He's always posting lots of really good visual aids that will help you to know where to use what drug at what EGFR and what the licensing say. He recently published the one that covers all of the renal stuff and the heart failure stuff. So a really good guy to follow on Twitter. Okay, what else have we got? How does dose escalate treatment with regards to frailty when we are trying to provide cardiovascular disease and renal protection? Who wants to take that one?
I'll take it.
Yeah.
I was just going to say, I was just reading that and I saw a very interesting tweet from one of the other Goggle Docs, actually, Amar Patana, who is, has a great interest in dealing with frailty. And actually they have started looking, and I think there was an article about using it in older people and actually showing that it reduced the risk of like cognitive deterioration in those people. So whilst obviously we would, probably be talking about using caution in people who are frail, who aren't eating and drinking maybe as well as they should be. I think it's dependent on that person really. But, just using it with caution, depending on, what we're talking about really with regards to frailty.
Yeah, I think it's clinical judgment, isn't it? I mean, if your patient's at risk of dehydration or fluid depletion, you're not going to be using a medication that might cause them issues. But if they're going to benefit from it and there's no issue there, there's different types of older person. Some are quite frail, and some, you wouldn't use it, but others, they would benefit quite well from these drugs. Okay, right, next one. There is growing confidence in primary care for using SGLT2. Fantastic. I think that's only going to get better, isn't it? Now that it's part of NICE. I think primary care have always been very using NICE a lot. I mean, us in specialist care, we tend to go away from guidelines and kind of look more towards, what's going on in Europe. And for the last few years, we've all been saying things like, oh, we follow ADA-ESD rather than NICE, because NICE is like 7 years old, wasn't it? So we didn't have an up-to-date guideline. But I think in primary care, the NICE guidelines are very sort of used very much, and so it's really fantastic that now that we've got a more up-to-date guideline that's showing us some great stuff from these cardiovascular outcome trials. And I think
it's going to be that SGLT2s will be a primary care drug, really, because they're going to be started at diagnosis. So, you know, they're going to be a drug that's used more in primary care than it is in specialist care, really, which is why it's so important that
it's going to become like statins, isn't it? It's going to be like, you
get
your metformin, you get your statin, you get you get
everything.
So that's something that somebody has put in the chat. I think we may get some patient resistant to trying to start them on so many tablets, metformin and a statin, and then an SGLT2 inhibitor in quick succession. But maybe this is where the mixed drugs come in, you know, where you get two drugs in one. Combination therapy. So we don't really use them very often, do we? But maybe
I think it's also like we were saying, how we're having to learn cross-speciality kind of working. We also really have to be careful to explain those things to patients and say to them, because so many patients that we're seeing come through, they know a little bit about their diabetes and maybe what high sugars do, but they don't understand that it's all connected to their blood pressure, their cardiovascular risk, their chronic disease, their heart failure. So it's really important when they're diagnosed that, you know, they're all supposed to come to a structured education. Do they all come? No, we know that they don't. So we need to be having those discussions as much as we can. Talk to them, you know, this is related to your cardiovascular risk, this is related to kidney disease, and explain those things and just drip feed it from the start. Because, you know, very often if you speak to them and explain those things, they understand, well, yes, why I'm taking a statin, why I need my metformin, and why I need my SGLT2. So it's just trying to have those discussions so early on, isn't it? Rather than waiting until, their H1C is now 100, they're 10 years down the line, they need to go to specialist care for all three of those specialities, like we've just discussed. Trying to have those discussions early.
So I suppose it's more of a focus on the prevention, isn't it? So rather than waiting to treat the issue, it's being proactive and trying to prevent it from happening in the first place. And I do think it's really difficult, particularly with people who are newly diagnosed who maybe haven't had any symptoms of diabetes, and it's obviously just being picked up as part of their annual screening. So they don't feel unwell because they haven't experienced any symptoms. So I suppose it's just trying to reinforce that prevention and that health promotion and the risks associated with diabetes and cardiovascular and kidney and, you know, heart, and those potential complications from the start. And I suppose it's difficult, isn't it, not making it feel like having tablets or medication is a failure, because it's not. It's part of their treatment pathway.
Rather
than... also it's like you said, there's like an inertia, isn't there, in the sense that, you know, that they start on a medication and then they may not be seen again because of work commitments and, you know, and things like that, and then they may not be seen again for another 6 months, and by that point, you know, their diabetes hasn't got any better. So actually I think, you know, from the outset, if you say to somebody, right, okay, we're starting you on this medication and we will be adding in this second medication once we know that you tolerate the first, so you've already given them that pre kind of expectation that that's what's going to happen. And also that this, you know, this combination of medications will protect your heart, it will protect your kidneys, and actually it will mean that hopefully down the line you might not need more medication, because actually it's already giving you those protective benefits, you know, and actually do it right from the start, rather than it being, you know, in a year's time, you know, you might need another medication. Actually saying in 4 weeks we're going to add in a new medication that's going to give you additional benefits.
Okay, so we've got lots and lots of questions, so we'll try and get through them all in the time that we have. Are there any contraindications to SGLT2 inhibitors, and how do you decide which SGLT2 inhibitor to start? Who wants to take that one?
Silence.
So contraindications to SGLT2 inhibitors,
I suppose you might, maybe if you do have, I mean, some patients you might say if they, you know, do have chronic thrush or UTIs, but it's kind of the chicken and egg, isn't it, is You know, could it be the hypoglycemia that's causing the thrush and UTIs, and maybe giving them an SGLT2 might potentially make it worse? But some patients, when you explain that, they kind of go, well, I've got it anyway, so I'll just put up with it if it helps my hypoglycemia. So that might be one thing that you definitely would want to speak to patients about.
And as we've already spoke about the EGFR cutoffs, you know, we're not going to use it in, and those people that are at risk of volume depletion or you know, particularly frail. There's also a bit of a weight reduction in some people, so I'd be a bit concerned if that person had a particularly low BMI, and maybe query and diagnosis if they've got a low BMI of what's their beta cell function like, because
sorry, I was going to say, it's interesting, the next question is about loop diuretic. So as well, you know, if they are on a loop diuretic, you'd maybe want to be cautious as well, mightn't you? Because obviously they're both going to volume deplete somebody, so you'd want to be careful about that.
Yeah, you generally want to avoid them in people who've had ketoacidosis. So people who've maybe been on one and had ketoacidosis and it's been stopped, then you wouldn't really want to be restarting that.
Yeah, I think if it's definitely the SGLT2 inhibitor that caused the ketoacidosis, and it might have been a completely different cause. If you know the cause of it and you know it wasn't the drug, then there's a potential. But I'm not sure I would want to restart it in somebody that's
like we're saying, start metformin, start SGLT. You can't really tell which might have done the.
Yeah, I think that step approach that would maybe start the metformin first, wait a few months, then start the SGLT2 inhibitor. I think that might be better, because obviously you get side effects from medications as well, don't you? So you need to know which one it is that's causing the side effects. So we've got about SGLT2 supposed to be stopped for someone who is fasting in Ramadan. I think one of you guys was looking at something on that the other day, weren't you?
I think there's mixed opinions on that, to be honest. I know probably when we very first started using them, we would probably recommend stopping it because of the risk of dehydration. But I'm sure more recently, so with the South Asian Foundation, and I know Wasim Hanif's done a lot of work around it. If I'm not mistaken, I think they do say that they can be continued, but I would have to double check on that. I don't know if anybody else has got any information on that, but.
I mean, I think they obviously do have the meals in the night, don't they? So, I mean, it's not that they are completely fasted. They're fasted during the day. So in a sense, it's only like you fasting overnight when you're asleep, or if you worked nights or something, you would still say to people to take that medication because they eat in the evening or overnight. So I think you just have to obviously give the advice about being cautious if they're not very well and all those sort of things, as you would do, sick day management, wouldn't you, as you would do with anything, because they're not completely fasted. They are able to eat overnight. So
yeah, and I think it's about risk stratifying your patient as well, prior to Ramadan, and the advice that should be given ahead of fasting, because obviously they should be seen, in advance of Ramadan, so that they've got the right advice as to what to do during that time.
I think Beth just found a link.
Yeah, there's a really good paper by Mohammed Hassanain, sorry if I pronounce his name wrong, but it's 2020. So specifically about SGLT2 use in Ramadan. So you could probably, if you type that into Google, I'm sure it comes up, and you can have a little read of it. I'm not sure if we can.
Yeah, it's called The Use of SGLT2 Inhibitors During Ramadan, an Expert Panel something or other. We might be able to put it in the chat in a second. One of our glamorous assistants from Orange Juice might be able to put that into the chat in a second. So there's a few questions asking, what's the name of the guy from Twitter and how do we access the information from Twitter? Well, first of all, you need to have a Twitter account. You need to follow firstly follow the DSN Forum, absolutely, and then follow the Google Docs. So that's Kevin Fernando, Amrit Lambert, Amar Patana and Patrick Holmes. So definitely really, really interesting stuff that comes from those guys. Really top level, above my head stuff.
I mean, they do all that. They stay up all night looking for the headlines in journal articles, so you don't have to. So absolutely. If you literally at the click of a button, follow them. You will
be up to date. And they've also got a YouTube channel as well, so it's really, really good for us. This is where we get all our information from. Okay, so would you not prescribe an SGLT2 inhibitor with a high HbA1c? Would that be what would be considered too high? I think sometimes when the issue with prescribing with a high HbA1c is the mechanism of action. So the SGLT2 inhibitors are making you pee out all the sugar. If the HbA1c is really high, what's going to happen? You're going to be peeing out all that sugar. So people will sometimes get, more at risk of getting thrush, more at risk of irritation and peeing for England because there's just so much sugar coming out. And also, I think if they are really high, are they symptomatic? Do we need to get those glucose levels down first before we then add in this SGLT2 inhibitor once we've got the levels down? So it might be that you need to use something a bit more like glycoside or something like that to get those numbers down before we start adding in the SGLT2 inhibitor. So what would be considered too high? I think
you've got to just a clinical judgment on your individual patient, and I think
definitely anything higher than it's sort of in the 70s, 80s, I wouldn't be thinking to start it until it's a bit lower than that.
Certainly, as you say, if they're symptomatic, because you're potentially going to exacerbate those symptoms. It's best to get the glucose down first and then reassess the situation.
So I'm gonna switch over to the Q&A bit, because we've got some in the Q&A and some in the chat, and I don't want to miss these ones in the Q&A. So there are many PCNs and GP surgeries promoting a low carb approach for type 2 diabetes and having great success at putting patients in remission. Where do you feel this fits in with the new guidance, adding in an SGLT2 soon after diagnosis? Would you still advocate lifestyle changes such as low carb before adding in any medication at diagnosis? Bearing in mind, SGLT2 inhibitors are not necessarily recommended if doing a very low carb diet. I think you've hit the nail on the head there, really, haven't you? Low carb diet, your risk is you could be producing ketones. SGLT2 inhibitors, you can also get ketones. We put the two together, we could end up with a DKA on our hands. Low carb, not recommended. Definitely, that is the major number one treatment for type 2 diabetes, and to get people into remission is diet, lifestyle. There are other diets, not just low carb, but definitely I think if they are planning that kind of trying to get it into remission, we might not, and also it depends where they are. If they're only just if they're only just 48 and then they manage to get it into remission, would you be starting any medications on these patients? I don't know. Okay, then we have, after explaining the cardio and renal benefit of an SGLT2 to patients, then unable to tolerate it can create anxiety. Do you recommend trying another SGLT2 to see if tolerance improves? What do you think?
I have done in the past, and sometimes it's worked and sometimes it hasn't.
Yeah, sometimes they get like you said, if you start it in them with quite a high HbA1c, they don't forgive you, and they're like, no, I'm not touching it. Sometimes, if they had a bit of a nasty reaction and things have got a little bit better, they're willing to try. Yeah, it's a hard one to answer, actually, isn't it? It's very patient dependent, but
So there's
same with the GLP-1s, isn't it? You can try mix and matching the GLP-1s, and some they get on with, some they won't because of the side effects. But.
So we've got, is there any difference in efficacy with a combined SGLT2 inhibitor and metformin medication, or is it just as good if you were to give them singly and give them combined?
I don't know if there's
we don't have one yet, do we? We don't have a combination one, but
I think there is one, isn't there? There is one. I don't think it's I think it's something that the pharma companies will probably be bringing out now that it's going to make our lives easier if there's two drugs. Okay, but I can't really answer that question.
I think the thing is, as well,
we can say, oh, sorry, Vicky, you go.
Sorry, I was just going to say, in the beginning, because it says to do it in a stepwise approach according to the guidance anyway, you wouldn't really be able to use a combination in that instance anyway, because you need to check that they're tolerating one before adding in the other. So
so maybe once they're on it and they're on the repeats and they're happy and whatnot, and then switch over just to make it easier, so they haven't got to take two tablets, they're taking just one. If we could mix the statin in with it as well, that'd be fantastic, wouldn't it?
Apparently they all have a combination therapy. I didn't know this. So
oh, wow.
I was going to say, I think I'd seen it, but they're not very well prescribed.
I was going to say, no. they don't advertise that well to us, do they? Right, since COVID, I'm seeing so many patients with very high HbA1c at diagnosis, 90 to 120 millimoles. I think that comes, would you not have reservations about starting SGLT2? I think we've kind of answered that question already, haven't we? That we would probably not start it until we've got that HbA1c down because of the side effects. Diabetes remission being such a hot topic. Do you think that starting several, so we've already answered that one. Then established type 2, worsening control, would you choose if patient had, that's the same sort of answer, isn't it? Over 100 asymptomatic, I think we'd be a bit concerned there with, and we'd probably be wanting to use something a bit more potent to get that HbA1c down before then switching on to the either.
I think as well, if you're getting a HbA1c over 100 at diagnosis, you might be thinking it might not be type 2 as well. Like, you make sure you're taking a really good history and things there, wouldn't you?
Yeah. Is there any guidance on patients with chronic pancreatitis with diabetes? So that I think we need to know the beta cell function, don't you? Because some people with chronic pancreatitis or pancreatic cancer or any of those kind of type 3C diabetes, they quite often they need insulin more than they need tablets. So I think it would depend on that patient.
I think as well with pancreatitis, they're so prone to getting well really quickly, and and not eating and drinking. I just think that would be a really high risk patient to be putting an SGLT2 into, really.
Yeah, there was a good article that was published the other day. There's an SGLT2 prescribing tool for type 2 diabetes. We'll see if we can add that link in as well. It kind of categorizes it into sort of like a traffic light system as to who is appropriate, who maybe you want to exercise caution, and those who maybe aren't suitable. I'll see if I can find that link and pop that in the chat.
Yeah. So I'll just go back to that.
This is a good one maybe for a kind of joint working. In my trust, we're finding that cardiology are starting frail elderly patients on SGLT2s and then asking the DSNs to review other treatments from a diabetes point of view. I don't know if anyone's got any, obviously not everybody who gets started on an SGLT2 from a cardiology point of view needs to be referred to the diabetes team, but maybe if we could just offer those that maybe would need a review.
Yeah, well, we get a lot of these referrals actually in my team, and we had to come up with a bit of a protocol of if the patient was started on an SGLT2 with diabetes on glycoside, that the primary care would manage the titration. So we might want to at least half the dose of glycoside, depending on what their HbA1c is like, or maybe even stop it completely. But we might want to ask that patient to, blood glucose monitor for a little bit whilst they're doing that process, so we can keep an eye on things and certainly talk to them about hypos and things. But if that patient's on insulin and cardiology add in an SGLT2, then they might come to the DSN team so that we can titrate down the insulin and manage that. But yeah, it's a good one, isn't it, of how, and like we're doing our brunch this Saturday with the heart failure nurses. It was a good one to kind of talk to them about, isn't it? I'll be quite interested to see what they say actually, because I think they're terrified of diabetes just as much as we are of heart failure drugs. So that would be a good one to talk to them about.
I have got a question for Vicky, and she's been priming herself for this one all day because we knew it was coming. Our local consultants recommend starting GLP-1 like Trulicity earlier based on cardiovascular benefits, yet NICE have chosen not to prioritise the use of this class. What do you think about that, Vicky?
Well, honestly, I think we're all a little bit disappointed, but from what we understand, the reason behind it is this particular review only looked at the GLP-1 receptor agonists in the context of cardiovascular benefit, and it wasn't deemed as being a cost-effective therapy for cardiovascular benefit in isolation. Unfortunately, the review didn't take into account the glucose lowering efficacy and weight loss attributed to using the GLP-1 therapy. So for that reason, they didn't review that part of the guidance. But the good news is, hopefully they're going to start doing this in the next month or so. Not quite sure how long that's going to take, but obviously they are going to do that full review. But I suppose we have got other guidelines to support earlier use of GLP-1 therapy, and we've also got obviously the trial data to support it as well. So I in my opinion, if you can justify why you're doing it, then there's evidence to say that it's good.
Yeah, I think NICE is very cost-based, isn't it? I mean, they've always said that SGLT2 inhibitors are really expensive drugs. For a drug to be deemed value for money, they have to come in at less than 30k per year in terms of cost effectiveness. There's a big calculation that goes on, and they work out the cost effectiveness.
That's above our pay grade.
Absolutely, we don't know how they work these things out, but actually all of the SGLT2 inhibitors, I think bar Inertia maybe, came in at below that 30,000. So now they're seeing the real benefit and cost effectiveness of those SGLT2 inhibitors, and the most cost-effective one that came out on top was dapagliflozin, and then I think I'm not sure which one was second after that, but yeah, so there's that. This is probably why they've been highlighted in the NICE guidelines more than the SGLT2 inhibitors at this time. So we only have a few minutes left, and I know there's so many questions, but you feel free to send those questions to us on our open Facebook page or Twitter, or if you're in the closed group, if you're a DSN, then send them to us on there. But we'll try and get through a few more before we finish. So there's lots of talk about glucose lowering benefits in it, but I think we've kind of covered that actually as soon as you start going in, because of the mechanism of action, as soon as you start going to a low EGFR, the actual glucose lowering is a lot lower. So
we've popped that link for the article with the traffic light system in the chat as well, so it's there now.
Okay, foot ulcers and amputation. This is always a frequently asked question. Who wants to take that one? Shall I? Okay. So there was one trial, it was the Canvas trial, that showed that there was an increase in people who were having amputations, mainly toes, I think, in that trial. And so everybody get a bit scared about using SGLT2 inhibitors in people with high risk of toe amputations. But every subsequent trial since hasn't shown that. And even the Credence trial, which was the same drug, canagliflozin, didn't show that increase, and so we're not sure. It's still in the license though, so they haven't taken it out of all the licenses of the SGLT2 inhibitors. So if you have got somebody and they are at risk, you know, it is still in a lot of their licenses, but until they take it out of the license, we probably do need to be cautious with people who we think are probably high at risk of having those toes amputated.
Yeah. It wasn't replicated in any of the other
right.
RCTs though, was it?
And we're expecting probably that it will get taken out in time, but at the moment it is still in a lot of their SPC, you know, caution.
It just reinforces, doesn't it, all the conversations that we need to have with patients when we're starting therapy, but also with diabetes. They need to be looking at their feet, they need to be careful with, you know, their eyes, all those kinds of things. So just reinforces those safety kind of chats that we need to have with people.
Right, we've got one person here saying we've been advised we advise it's cheaper to prescribe a combination empagliflozin, metformin, locaine. It probably is cheaper to prescribe a combination, but like somebody was saying earlier, all of the companies are probably going to be coming out or have already come out with their combinations, so that's a good thing. Any other questions? Oh, the Q&A's up again. I thought I'd done all of that. Oh, SGLT2 and Fournier's gangrene. So this is the last question. So who wants to take that one?
Yeah, I can. I looked at this actually the other day just for my own learning, really. So it is rare. I actually looked at some data from 2 different trials, and actually in one of the trials, 5 people in the placebo group had it compared to 1 in the intervention arm. And then in the other trial, there was only 1 case in over nearly 6,000 patients. So it's very rare. It does exist, but it is very rare. So I guess the most important advice we can give is obviously good personal hygiene and advising our patients on when they would need to seek medical advice, because we know that if it happens, it can excuse me, progress quite quickly and can be very serious. So it's knowing when to seek medical advice.
Yeah, I've never seen it myself. Right, I think we are just about out of time. So I would like to say thank you very much to my fellow DSN Forum colleagues. Thank you very much to Orange Juice Communications for helping us set up all the techie stuff. And thank you so much to Lisa, who is our secretary, for setting up everything. And finally, AstraZeneca for sponsoring, and to all of you guys, all 100, I think we had 130 at the peak, so amazing turnout. Thank you so much, and we shall see you again when we do another one.